Good afternoon, everyone, or good evening. I'm so grateful that you stayed till the last, and I hope I make it interesting. My topic is management of diabetes mellitus in office practice. I am not going to talk about insulins or DKA or doses of insulins. I'm going to talk about the questions that the parents and the children come to you once they have been diagnosed with diabetes. Yeah. So how can diabetes present? As we all know, the classic triad of presentation of diabetes as polyuria, polydipsia, and weight loss, but 50% of children do not present like this. They can come to you with general malaise, weakness, loss of energy, headache, pain abdomen, irritable, ill-tempered, bedwetting, blurring of vision, leg cramps, infections, or genital itching in girls. So they can present to you as any symptom. So that is why it is very, very important that any sick child, you check the blood sugar. Or they can come to you in an altered consciousness or coma. So diagnosis of diabetes, as we all know by definition, is that symptoms of diabetes plus a random blood plasma glucose of 200 milligram per deciliter or higher, fasting blood sugar more than 126, or postprandial blood sugar of more than 200. Diabetes management has three basic steps, that is blood glucose monitoring, insulin, and the meal or the lifestyle. This is the basis of ideal management of type 1 diabetes. Now, our therapeutic objectives are basically to eliminate the diabetic symptoms, prevention of acute complications like DKA and severe hypoglycemia, keep HbA1c less than 7%, blood sugar ideally 80 to 110 for fasting, 100 to 140 before meals, and less than 180 after meals, normal growth in puberty, early detection of associated diseases, and prevention of chronic vascular complications. Now, management issues. The basic problem is that children are not miniature adults. Because sometimes what happens is that when they go to adult endocrinologist, because diabetes, they don't know that pediatric endocrinologists exist. So they go to adult endocrinologist and they put them on fixed doses. They put them on mixed ARDs. सुबह ले लो एक injection, शाम को ले लो एक injection, काम खत्म. But what happens is that they are not miniature adults. They do not have fixed schedules. Consistency in lifestyle is not there. Sometimes they have school, sometimes they have holidays, they have sports, they have exams. Sometimes उनकी पसंद का खाना बना है तो ज़्यादा खा लेंगे, नहीं बना है तो कम खाएंगे या नहीं खाएंगे. So fixed doses do not work for children. So that is why it is very important that multiple doses of insulin are given for good control from the beginning. Because you start them on 2 injections and you say, okay, we'll increase it to 4, that will not happen. They will change the doctor. So that is why it is very important that the right treatment is started from the beginning, and they require frequent monitoring and dose changes. I have had so many patients जिनको डॉक्टर ने कहा है कि एक हफ्ता चेक कर लो, उसके बाद अगला एक हफ्ता उन्हीं रीडिंग्स के बेसिस पे इंसुलिन लिए चलो. That will not happen with them. So that is why frequent monitoring has to be insisted in these children. Now, aim of blood glucose monitoring, as we all know, is decrease the occurrence of severe low and high blood glucose levels, improve overall glucose control and improve HbA1c, limit hypoglycemia, empower patients to make adjustments, because they are the ones who are going to manage their type 1 diabetes for life, because right now we do not have a permanent treatment for this, which will all lead to reduction of complications. Storage of insulin, this is a very important question that they might ask you in your OPD. So they should not be exposed to temperatures more than 25 degrees Celsius or frozen. There should be no direct sunlight exposure. Unused vials and cartridges should be stored in the door of the refrigerator or in the lower compartment of the refrigerator, not in the freezer, not in the chiller. And pen should be kept in refrigerator in summers. Winters, it can be kept outside. Now, change of site of insulin injection is extremely important. It is very important that we tell them which are the sites where they can take injections, and we ensure that they rotate, because if they do not, they can have lipohypertrophy or lipoatrophy, which will take months or sometimes a year to get resolved. Honeymoon phase. This is something very, very important which happens after you start the treatment for a newly diagnosed type 1 diabetes. It's a partial remission of type 1 diabetes mellitus. It is characterized by reduced insulin requirements while good glycemic control is maintained, because some remnant beta cells start acting again. Can last for weeks to years. can happen and it might not happen in some children also. But we cannot let our guard down, and we have to keep frequent monitoring in these children, because you have to tell the parents कि ज़रूरी नहीं है कि ऐसा ही रहेगा. And if they do not monitor, if the blood sugars will start rising, they will not come to know. Diet, the most important thing. किसी को भी टाइप 1 डायबिटीज डायग्नोस होता है, सबसे पहले माँ पूछती है कि खाने में क्या खा सकता है, ये जूस पी सकता है, ये फल खा सकता है, आइसक्रीम खा सकता है, चॉकलेट खा सकता है. दैट द मोस्ट कॉमन क्वेश्चंस दैट यू विल गेट. So what we try to tell them is that they can have as normal diet as any other non-diabetic person, but they would have to avoid pure sugar in large quantity. We never tell them that you have to stop any fruit. I have never told my patient कि आप आम नहीं खा सकते, आप बनाना नहीं खा सकते, आप लीची नहीं खा सकते, आप अंगूर नहीं खा सकते. ऐसा कुछ नहीं है. They can have all the fruits that they want, but the quantity has to be determined and it has to be covered adequately by the insulin doses. So they can have everything that they want, but it has to be in a planned manner. And consistency in timing and amount of food consumed is important. Meals should be timed according to the insulin schedule. That is very, very important. We have to tell them the work timing of insulin and that they have to have their food within that time, because insulin will not work according to their time. They will have to work according to the insulin time. That's the limitation that we have. But that limitation is somewhat removed if they are on insulin pumps, because insulin pump gives you that flexibility of eating whenever you want and taking the insulin for that without pricking yourself repeatedly. Exercise, very, very important. It gives a sense of well-being, improves glycemic control, improves the cardiovascular risk factors, lipid and BP, and helps maintain the desirable body weight. The children who exercise regularly have better blood sugars in their entire day. Few things to remember when a child is exercising is to measure the blood glucose before, during and after physical exercise. They should have a snack for every half an hour of physical activity, and there is increased risk of hypoglycemia about 12 to 40 hours after strenuous physical exercise. So that is something that the parents might come to you worried कि exercise तो करता है मगर उसकी रात शाम को करता है, रात को जाके उसकी blood sugar low हो जाती है. So that can happen and that has to be kept in mind. And blood glucose before bedtime should be more than 100. Now, what is hypoglycemia? Blood sugar less than 70. Symptoms can be anything: shaking, sweating, anxious, weakness, fatigue, headache, irritable. They can present like anything. So what are we supposed to do? We are supposed to check the blood sugar right away. We have to treat. Please, माँ बाप को प्लीज़ बता देना कि बिस्किट, चॉकलेट, दूध में चीनी, मिठाई, ये सबसे हाइपोग्लाइसीमिया नहीं ट्रीट करना है, because these things take time to get digested, for the blood sugar to go into the blood circulation and to reach the level. It will take time. So it is very important that pure form of sugar is given, either in form of glucose or sugar directly, or glucovita tablets or juice, that is preferred, and repeated checking of the blood sugar till the child's blood sugar comes to normal. And what is hyperglycemia? Blood sugar more than 250 to 300. Again, symptoms can be extreme thirst, frequent urination, hunger, nausea, blurred vision. So again, we are supposed to check the blood sugars, and if they are higher and you do not know why, you will have to call your healthcare provider to give adequate management. Otherwise, the child can land in decay. So decay only does not come at diagnosis. Decay can happen later on also if hyperglycemia is not treated adequately. Sorry. Sick day rules: do not stop insulin. This happens so commonly that खा ही नहीं रहा था तो हमने इंसुलिन ही नहीं दिया बच्चे को, and the child lands up in decay in hospital, because whenever the child is sick, their insulin requirement increases. So even if the child is eating less, the parents are supposed to give insulin. That is very, very important, that we are supposed to insist to every parent of type 1 diabetes child. And frequent blood sugar readings should be taken, especially at night time. And ketones should be checked even if blood sugar readings are normal or mildly elevated. This is to diagnose ketones early and not the child, prevent the child from going up to decay. Strenuous exercises should be avoided. And normal diet should be insisted on. They can take small frequent meals of easily digestible food like soup, toast, milk, tea, etc. And diabetes team should be contacted. When to go to hospital, that is very very important, that they should know when they should take the child to the hospital. If the child is very young, fever more than 100 for more than 2 days, persistent vomiting, diarrhea, large ketones, becomes drowsy or unconscious, or showing any symptoms of decay, they should be taken immediately to the hospital. Now, school. We have had a lot of kids, once diagnosed with type 1 diabetes, the school has asked them to change the school because they do not want a type 1 diabetes child in their school. They would not allow the child to check blood sugar or take insulin in the school, or they would not, the teacher would not take responsibility that, if we tell them, ki, okay, the child would be taking the insulin themselves under your supervision. They would not even allow that. So that is why we have now government approved guidelines which say that if any school refuses admission to the child or asks the child to leave the school, they are not allowed to do so, and they can be implicated for that. And academic expectations should be same. Teachers and school nurse should be informed about general rules and emergency status, and written material about diabetes should be handed out, and a close communication should exist between home and school. Now, traveling. It is very very important that before traveling they meet their doctor and improve metabolic control, and they should be capable of treating hypo and hyperglycemic episodes, and they should know about sick day management, and they should have a travel health insurance which is valid, and should carry all the things, insulins, blood sugar monitor, ketone sticks, glucagon, and everything which is required should be taken by them. Psychological issues in diabetes, it has a profound impact on family life, as we all know, and potential to cause serious personal and family distress. Pre-existing psychological, social and financial problems are likely to get accentuated by the stress. Parents usually are in shock at diagnosis, and they have denial कि हमारे बच्चे को तो हो ही नहीं सकता, हमारी फैमिली में तो किसी को है ही नहीं, तो ये तो हो ही नहीं सकता. So they go to Baba Ramdev or they go to some other place to get it cured, and then they'll end up in decay again. That's a different story. Young children, they have needle phobia and eating problems. So giving insulin, you give insulin and they say, I will not eat. Then they go into hypoglycemia. Then they eat. Then they go into hyperglycemia. So these things can happen in very young children, and that is why doses need to be modified according to their eating habits. Adolescents, poor compliance, insulin omission, eating disorders is quite common. Now, this is one thing, surreptitious insulin administration, that is very, very important for us to know. It happens starts around 7, 8, 9 years of age, when they start taking the insulin themselves to eat something that they want and do not want the parents to know. So we have a lot of kids who have been taking insulin themselves. So you have a 200 blood sugar in lunch, and 2 hours later it is 43, and the mother is like, इसने तो कुछ खाया ही नहीं खाना खाने के बाद. And then especially at night post dinner it is 150, and we check at 2 a.m. it is 35. So these all indicate that the child has taken extra insulin. First of all, parents do not agree to it, but most of the times this is we get to know when we probe little more. And it may not be a suicide attempt, it is a escape from stress, or by eating, and or maybe related to a severe personality disorder. We have had a girl who is a topper in her class, and she has been taking insulin by herself, going to 25, 30, 35 blood sugars. And so first I asked the parents to find out, they disagreed, then they found out she is taking insulin, then they started keeping the insulins logged, blood sugars better ho gayi. Thode din baad the blood sugars again 30, 35, 40. Then again what they found out was that she took the cartridge, she had hid an old pen, she took the insulin from that cartridge in a syringe, put it in the old pen, put water in the cartridge and put it back in the fridge, so that the parents would not know that she has taken insulin, and she is self-injecting. So they can go to any levels डांट खाने से बचने के लिए या कुछ ऐसा खाने के लिए which the parents would not let them eat. So this is something that can happen and should be looked into. So follow-up every month is required, height and weight should be measured, pubertal status should be assessed, injection sites should be checked for lipohypertrophy. and look for limited joint mobility. This can happen in severe diabetes which is very, very poorly managed. Blood glucose log should be checked, and HbA1c and yearly investigations should be done for other autoimmune disorders. Long-term complications can be growth retardation, delayed puberty, short life expectancy, and poor quality of life. This is an 18-year-old girl who had come to us, and she was a very, very poorly controlled type 1 diabetes, and her height was about of a 9-year-old only. So laughter is the best medicine. Well, unless you are diabetic, then insulin is probably better. Thank you.
Thank you. I wish many of the people who have left were here. I hope you will hear the recordings only. It was a very good session. 10,000 audience.
Thank you, Dr. Swati. It was really a very nice, crisp, and comprehensive talk. So I would just like to add a couple of points. I think when we have a child with type 1, it's important that we have a multidisciplinary team approach. So the team should involve not only a doctor, a diabetes nurse educator, a dietitian, a mental health expert should be on board always, because as Dr. Swati very well said, that when a child is diagnosed with type 1, it is actually a state of shock. And initially it is a state of denial, and parents not often more than that they will never accept the condition. So they would run from pillar to post to get a doctor who would get them rid of the insulin and put them on oral hypoglycemic agents, or maybe come down on the number of dosage of insulin. As Dr. Swati said that the most important treatment modality is basal bolus therapy that requires multiple daily dose of insulin injections, and they would do anything. And most of the, I would say, the people who are having these non-medical aspects, they would actually take advantage of the honeymoon phase and probably, get down on the dose of insulin or get some oral hypoglycemic agents, taking advantage of the honeymoon phase that, okay, the child's dosage requirement is really less. So this is something extremely important, and having a team on board will get the patient or the family the right message right from the start. And this team should be available 24/7 with the family, with the parent. And education is one thing which is the cornerstone of management. I would say that empowering a child and a family with the management strategies that is called as diabetes self-management makes the child and the family empowered well enough that even in the absence of doctor, the child doesn't require anybody. So that should be the motive or the objective of the presentation. So very well presented, Dr. Swati.
Thank you.
And any questions from the audience?
So just to conclude, thank you, Dr. Swati, for bringing these very practical points. As a geneticist, parents do approach me with very pertinent question regarding risk of recurrence, especially if they are planning another child. So the counseling which I do for these families is that type 1 diabetes, you have to tell them that it's a multifactorial disease. There is an underlying genetic component which is influenced by the environment. The genetic component is also not very simple. It is not a Mendelian inheritance. It's not a monogenic disorder. Rather, it's a polygenic. It's polygenic in inheritance. There are a number of loci with small effects, again, which are influenced by the environment factor. The genetic component, the HLA, the contribution of HLA, we are all aware of. So, an empirical risk, which I always tell these families, that the age at which the proband, the affected child, has presented, that matters. If it's an early presentation, especially less than 7 years, then the risk to the sibling is higher. If the sibling in question is a male, then again the risk is higher. If we are able to do the HLA typing, and if it's one allele sharing, then it's about 3 to 8%. If both haplotypes are shared, then the risk rises to 12 to 20%. And if it's a monozygotic twin, where they share 50% of the genes, then the risk rises up to 50%. Again, the environment does play a lot of role, which can always be influenced. That is in your hands. So, thank you, Dr. Swati, once again.
Thank you. Thank you so much for a very interesting session and very practical for pediatricians.
I request Dr. Swati and all the chairpersons to please move to the right side for felicitation, and I invite Dr. Shika Mahajan to please do the felicitation. So I hope at the end of this one day CME, at the end of this day, you everyone is walking out wiser, intrigued, motivated, nevertheless entertained. But it takes an entire team